the next speaker of the session is Dr. Benedict Weobong. Dr. Ben is an intermediate fellow of India Alliance and works at Sangath, Goa. He is among the few non-Indian nationals who has received the India Alliance Fellowship. He's from Ghana and he's a mental health epidemiologist. His research interest spans from child development, adolescent health and mental health, maternal health and well-being. Today, he would be speaking to us about tackling the treatment gap for adolescent drinking problem. Thank you. Over to you, Ben.
For a very successful 10 years and the science rendering and giving all the support for another decade. And as fellows, we think that we have a role to play here, and we will definitely want to see that you have another successful decade, and that other fellows will be here to say the similar thing in the next 10 years. I also just want to say I'm here with my team who have supported me, who have always been with me for almost 2 years into my fellowship. And so I have Sandra and Suraj here and Lydia here, who would be talking at some point during my presentation. So I'm going to try to move away from the biomedical sciences a bit, which is always a good thing for some of us, because then we can get to talk about some other things, some other interesting behavioral issues that affect most of us. And most importantly, I'm going to try to talk about the issue of drinking problems in young people and adolescents, and try to argue and present a case for coming up with innovative strategies. I mean, as scientists, I think what we are encouraged and motivated by is to come out with innovative strategies in whatever we do in our labs. And there's a very good reason for that, because obviously we have to keep innovating given the way trends are beginning to be recorded. We have a problem, and we think that we couldn't continue doing, what some people have said in the past, work as usual. We have to start thinking about newer ways of doing things. And so that is my passion, and my passion is to try to come out with newer ways of addressing the treatment gap for adolescent drinking problems using digital health technology. I'll just start off by giving you a brief of what the current situation is and why we should be interested in this topic. Globally, 5% of all deaths, the WHO reports 5% of all deaths in 2016 were attributed to alcohol directly or alcohol-related problems. And if you juxtapose that with the other metric that we use to calculate the DALYs, which is years lives lost with disability, you would realize that there is a certain increase in burden. And it has been increasing from what this slide shows you. It has been increasing between men and women. It has been increasing from 2004 to 2012. We have seen almost threefold increase. And in 2012, what we are seeing is that it does appear that it's stagnating with men, but what we are seeing is that for women, it is increasing. And that's, for me, it's a worrisome trend. And if we may begin to think of why this is the case, and given that we already know about half of mental health disorders or mental health problems have their onset in childhood and adolescence, we want to begin to think about why this is the case and begin to address the issues as they come. So now moving on and putting the searchlight on adolescents, which is the area of my research and my interest. I just wanted to give you a flavor of what we are looking at in terms of the top 10 contributors of DALYs. And I'm sure most of you already know this, but just to reemphasize that alcohol is there, and it's prominently represented. It's on the 6th rank. But if you look at the other causes, road accidents, and many other causes that you can see on this list, it's clearly suggestive that there are some other alcohol links on the tones to this. And so when you club this, you can agree with me that it probably would be the first, the most important cause of DALYs in adolescents. So then the question is, where is this happening? Where are adolescents drinking most? And for the purposes of this talk, I decided to look at the regional distribution of what, and based on the very latest global status report on alcohol, 2018, which was published a couple of months ago. And what we are seeing here, and what I'm flagging up here, is that the Southeast Asian region is it's quite it's becoming problematic in terms of how our young people are drinking. It's second to the Western Pacific region. And so that already tells us, and the review, the report clearly says that with the projections of 2025 of how things are going to pan out, it says very clearly that the Southeast Asian region is going to be the main driver of alcohol problems in the world, whilst we are seeing a decline in other regions. We're seeing an increase in the Southeast Asian region. So clearly, this means that it's definitely of public health concern, and we should begin to do things to see how we can prevent that from escalating any further. The sad picture is that even with these stark realities of the burden that I've just tried to put out there, it's not being matched with how we are handling it and how we are providing care. And so there's this yawning treatment gap. And it's so massive that I'd wondered what you would guess. But there's an interesting slide that anytime I talk about it, people wonder, they always think that, as we have always said, it's beginning to be a very common password that most of the problems are in Islamic settings. But what we are seeing here is that when it comes to alcohol problems and many other even mental health problems, the treatment gap, which is that the number of people who have a case or who have a disorder but do not get the required treatment, that gap is almost comparable to what you find in low and middle income countries, so just a shade above that. In India, it's up 85% for alcohol problems. And that is not surprising because India has less than one mental health professional per every 100,000 population. And so that is not surprising. And but with this data, we need to start thinking innovatively, and that's what I said in my introductory remarks. What do we then do? How do we go about this? WHO usually will show leadership in most of this, and so WHO came up with their strategy to deal with this. And WHO's strategy was to introduce what we call the Mental Health Action Gap, which gave birth to the Mental Health Action Intervention Guide, which is essentially a guide that primary health care physicians will be able to use. You just basic training, a few weeks training of it, and you'll be able to use to provide, to detect, to screen, and then provide immediate care to people who turn up with mostly common mental disorders. And that also includes alcohol use problems. Featuring very strongly in the Mental Health Action Gap is the role of psychological treatments. And psychological treatments, as the name suggests, are just treatments that, one of my colleagues said very simply, they're talking therapy. So it's treatments that use talking techniques and try to change people's emotions, thinking and feelings and behaviors, and try to help them deal with their interpersonal relationships with a goal to attain recovery. And there are these examples of psychological treatments that are now evidence-based, so CBTs and behavioral activation, interpersonal psychotherapy. These are all great, and that has come up because of years of very good accumulating evidence about their efficacy and actually effectiveness as well. So we do know that psychological treatments do work, and they are very attractive because most people probably would prefer that than to get a pill or a jab. So that is something that we in global mental health have been trying to further in terms of providing treatment. An offshoot of psychological treatments is what we call behavioral brief interventions. Brief interventions are specifically directed at in the alcohol field, in the alcohol domain. They are specifically used to treat alcohol use disorders. And they are targeted at non-treatment seeking population. So essentially, you just turn up at the hospital for some other condition, or the primary care for, they are delivered mostly at the primary care anyway. And you turn up for some other condition, and the doctor uses that opportunity to have a very quick, brief chat with you about, ask pertinent questions about your lifestyle, including alcohol, and then gives you advice. And what we have seen is that type of treatment, or those brief interventions, have really been very, very effective in helping people deal with their drinking problems. And so there's lots of interest now in that. I mean, if you can really do something in a very brief period of time, and it's working well, why don't we see how we can capitalize on that and use it? The problem is that it's not that big of a problem, but the only thing that I tend to differ, and that's what is informing my work going forward, is that there is a certain dominant treatment model, or the most frequently treatment model that we are used to, which is usually the face-to-face. So there's always the very typical biomedical approach to handling cases or dealing with, so patient-doctor relationship. So you need someone, and you have to talk to them on a face-to-face. And that is what has been with us from time immemorial, I guess. But of recent, there has been some very interesting, provoking discussions about that. Alan Kasdan, a very, very renowned psychotherapy researcher, is beginning to question and asking if we really want to make mental health treatment accessible, which clearly at this point we are not really scratching the surface that well, then we need to begin to think innovatively about doing something different from the face-to-face thing, because that may not work. And these are very interesting arguments that I tend to side with, which is, I just described what it is, the treatment sessions that are provided in person. You usually need to have a highly skilled or trained mental health professional. And now I can add that even with tax sharing and tax shifting, we have been able to redistribute very minimal tasks to people with less qualifications. But even with that, you still need counselors. You still need those lay counselors. Sessions are usually held in a given place. You have to move to a clinic, or someone has to move to you. So I think that these, even though they're great and I think they have helped us all these years, but I think that if we really want to think about how to then get mental health services out there, there are challenges, and the challenges that I think this obvious one comes up with is that access to treatment is a problem if you continue with this model, because obviously we don't have enough. That the simple truth is that we don't have enough. I just said India has less than 1 in 100,000 mental health professionals. We don't have enough to handle the population. Then there's also the issue of the availability of distribution of professionals. So we do know that mental health professionals, some people specialize in child psychiatry and many other things, which are very, very well sought after. But unfortunately, we don't have many of those specializations in the field. So then it means that where there is a huge need, we really don't have the matching professionals or services for them. So that is what, and the last obvious challenge with this model is that obviously, the whole stigma thing. I know how mental health is supposed to be a whispering discussion in most places, and so then to have people going out there to actually go seek help and be seen as probably having a mental health condition may be counterproductive. So, because of that, we in Sangath, and for this particular fellowship, I thought very strongly. I mean, obviously, the public health burden is made, the case for interventions is made, but then how do we then deal with the issue of the treatment gap, and how do we, especially for an adolescent population, how do we go around this issue of given what I've just laid out there in terms of the challenges with the dominant model. So I then said that, well, one thing we could do is let's leverage on technology. Let's sit down and see if we can reach them remotely. Obviously, there are, so my key goal is to address this treatment gap delivered through technology. And what I am beginning to these days is becoming a buzzword in most of my talks, is what I'm beginning to call digitization of tax shifting. So, as I said earlier, tax shifting is traditionally still delivered. Even though tax shifting, you are definitely redistributing the smaller tasks to people who are less qualified, so you're able to get more people to do it. You still do need a human factor. You still need a human factor. I'm not in any way suggesting that the human factor is not important in psychotherapy, but I'm saying that if we do want to really reach many people, we need to start doing things innovatively. And it may not just be one model, it may be combining models. So one of the things that I'm thinking about is to begin to think about how to digitize tax shifting. And that is what my fellowship is about. And the case, particularly for why I'm doing this, I've already laid it out a bit, but just to reemphasize the case in India, that in India, the minimum age of initiation has dropped. This is very, very cautionary note. This is a study that was done in just one state. But what we did find there was that it has dropped from 19 to 13 years. So the young people are beginning to go out there and start drinking much earlier than it was the case in 20, 30 years ago. And about 20% of them drink in risky patterns that suggest hazardous drinking. So my work is focusing on hazardous drinking. And I know a colleague, I was just chatting with a colleague over coffee the last time, and I needed to clarify that we are dealing with the less severe. It's also a concern because if you, like I said in my last bullet point, if you don't tackle it now, it's likely going to have consequential effects in future. But that is where you find more people actually with that problem. So we are tackling hazardous drinking. It's not harmful or dependent drinking. It's not those people who have drinking problems, as in they are dependent on drinking. We are not tackling that in adolescents. We are tackling hazardous drinking, which has potential causes for drinking problems later in life. And it's interesting when we started doing this work, before I put in this whole thing, it was all about reading up the literature and knowing what is going on in India. But when we started, we got more validated in terms of the work we wanted to do when we started seeing things like this popping up in Goa, where we have adverts for drinking competitions. And your guess is as good as mine who the target group would be for this. That's very worrying. And so, as I said, BI's brief interventions are great. They are efficacious. They are able to reduce drinking by about 23 grams in adolescents in some studies done in the West. But we don't know how they are generalizable in our setting, 1, 2, among adolescents, and even delivered over technology. So 3 questions that we think are very relevant to want to answer here. And so that's why we're saying that we don't know, we don't have comparable data in our setting. So our question is, can POWERTXT, and what we call our project is, our intervention is called POWERTXT. That's our running popular type name of the fellowship is POWERTXT. And essentially it's trying to harness the power in a textual form to see whether if you use that to deliver a brief intervention for adolescents aged 18 to 24, whether that would be able to reduce hazardous drinking. And more importantly, what we want to find out is the mechanisms of change. Most of these studies that have been done have just been able to, let's say, more cross-sectional descriptives of what they found, but we want to go beyond that and be able to find out what really created this change, what made and what were the elements of the psychological treatment that helped make the change. So we came out with a design. So our design is an intervention that is phasic, and it's also delivered, looked at in terms of sessions. So we have 3 phases: the orientation phase, personalized feedback. The adolescent will get personalized feedback and try to orient the adolescent at the start. And then the next phase of it is to set some goals, and then to try to learn some skills. And then the last phase is to be able to build skills to maintain that. And then we are going to have an interactive element to it where obviously it's a chatbot, so they are going to be typing and getting some feedback from the robot, and it's all personalized action plans that are also included. So the features, we have 4 main components or features of our intervention, POWERTXT. So we are still coming up with a name for our chatbot, but we are looking at the chatbot being able to deliver messages. We're going to use animations. We're going to also use infographics and videos to try to change behavior. There's no time now. I've just been told that I have just 5 minutes, and so I will skip. I wanted to show you a video clip, just a trailer of one of the clips that we have prepared, but there's no time. One thing, the key lesson so far is that we think that there are definitely quite interesting similarities between drinking problems here, how adolescents drinking behavior here and in other places. The only thing that probably stands out is that there seems to be some stronger cultural norms here, which we think we are going to capitalize on for our intervention. It's always good to think forward because we are beginning to think about how this can potentially be scaled up if we do find an effect. And we did rely so much on our data. So one of the key, hopefully what we hope to get out of this is by the time we finish this, we should be able to have a methodology for delivering brief interventions over mobile messaging. And hopefully there is a program that the Indian government has just introduced, the RKSK program, which has emphasized this. So we hope that we will be able to contribute some useful data in that program. How many minutes do we have? 2 minutes, okay. Okay, we just want to talk a bit more about one of our things, public. Well, there's no time, Lydia. Sorry about that. I wanted Lydia to talk about the public engagement thing, so I will just skip about that. But we just got a public engagement grant to support our work for the fellowship, and which is very useful. So I'll just skip that. But one of the things I was also asked to talk about in this is that to share with you how this fellowship has helped me. Three key things. The mentoring has been amazing. The whole mentoring arrangement for as an intermediate fellow, you are supposed to have a mentor. And that has really, really helped me so much. And it's gotten me to be able to have, to even translate those benefits into Sangath, where I've set up a mentoring scheme, a mentoring system in Sangath, where we have picked up international people to mentor people in Sangath, potential high flyers in Sangath. So that got me to be able to, motivated me to be able to do that. Amazing networking opportunities with this fellowship. I mean, the last couple of months ago, I think in May, we were in Joburg with under the invitation of Deltas. And through that, I'm beginning to talk to colleagues in Africa to see how we can collaborate on research projects. Obviously, I'm beginning to be asked to sit on and get more, collaborate on research grants that are difficult to accept because of my role, my time on the fellowship. But that is clearly what is beginning to see, and I'm currently giving some mentoring support to some of the students also. So this is just my team. I introduced some of them earlier on. This is my core team and my field team, and then Lydia here, my intern, who has come to join us for a couple of months. And I just want to end by saying, Dhanyawad. Did I do well with my?
Thank you very much, Ben.
Yes.
So in the interest of time, I think we have to take only 2 questions, brief questions. One of you.
Weobong, wonderful presentation. I work on chronic diseases in rural Gadchiroli, and alcohol is a big risk factor. You said that one of the comments you made was BIs don't seem to work in low middle income countries. Can you please elucidate on that a bit?
No, so I'm saying the evidence-based for their effectiveness is not that well established in low and middle-income countries. I think you can say the jury's out for high-income countries, but not in low and middle-income countries.
What's the typical endpoint that is, what's the primary outcomes have been used for BIs? Is it change to non-harmful drinking?
Yes, so it is about reducing. So it's more about reduction, and so it's not to get them to absolutely stop it. It's more about reduction.
And what's the typical effect size?
Interesting. So that's what I just said. That in one of the meta-analysis that we cited, that had mostly high-income country studies, they were able to reduce it by about 0.25 of the standard deviation. So it's quite small. But I guess the question is that if you can achieve this With the larger, I think it's more about the coverage, and that's what we are trying to capitalize on. So even though the effect sizes may be small, if you're able to get it to more people, at the end of the day, it makes public health sense.
One question there. One last question.
Thank you. Great presentation. I just wanted to know, do parents confound your BI, or do they actually help in this process?
Parents?
Parents.
Right. So when it comes to adolescents, and especially adolescent drinking behavior, the theory and the framework suggests very strongly that parental involvement could either be a positive or a negative. It's one thing that you have to address the environment of the adolescent, where the adolescent lives. So, for instance, what the adolescent sees around. If he sees a certain behavior in the parent, he may, modeling is very, very, very common. But the adolescents are also very, very private people. They want to, when it comes to that, they want to keep things like that to themselves. So, in fact, that was one of the reasons why, someone was going to ask me why we started at 18, but one of the reasons why we did that, I mean, apart from the fact that the burden increases as they age, the older adolescents, is that we were really concerned about the potential for this to create trouble at home when the parents get to know that the adolescents are drinking. So we struggled with that a bit, and then we thought, well, we are not, at this point, we don't really have the answers to that. We will definitely think about answers for how to tackle this later. But yes, parental involvement can be either good or bad, yes.
Okay, thank you very much,
Okay,
Ben,
thank
for a very interesting talk.
Thank you very much.